Welcome to Renal Care Radio, a podcast exploring all topics in the kidney care arena. One of the significant complications associated with CKD is mineral and bone disorder, primarily due to dysregulated phosphorus metabolism. Effective management of phosphorus levels is crucial in CKD patients to prevent vascular calcification, bone disease, and cardiovascular morbidity. Phosphorus is an essential mineral involved in various physiological processes, including bone mineralization, energy production, and cellular signaling. Under normal conditions, the kidneys play a vital role in maintaining phosphorus homeostasis by filtering and excreting excess phosphorus. In CKD, declining kidney function impairs phosphorus excretion, leading to hyperphosphatemia. As CKD progresses, the kidney's ability to excrete phosphorus diminishes, resulting in its accumulation in the blood. Elevated phosphorus levels stimulate the parathyroid glands to produce more parathyroid hormone, PTH, which increases bone resorption and releases more phosphorus into the bloodstream. Additionally, FGF23 levels rise in response to hyperphosphatemia, promoting phosphorus excretion by the kidneys and reducing intestinal absorption. However, in advanced CKD, the kidney's responsiveness to FGF23 decreases, exacerbating hyperphosphatemia. Hyperphosphatemia in CKD patients is associated with several adverse outcomes, including vascular calcification, bone disorders, and cardiovascular disease. High serum phosphorus levels contribute to the deposition of calcium phosphate crystals in blood vessels, leading to vascular stiffness and increased cardiovascular risk. Elevated phosphorus and PTH levels disrupt normal bone remodeling, resulting in conditions such as osteitis fibrosis cystica, adynamic bone disease, and fractures. CKD patients with hyperphosphatemia have a higher incidence of cardiovascular events due to vascular calcification and arterial stiffness. Effective management of phosphorus levels in CKD involves dietary modifications, pharmacological interventions, and dialysis. The goals are to maintain serum phosphorus within the target range, minimize vascular calcification, and preserve bone health. Limiting dietary phosphorus intake is a primary strategy. Foods high in phosphorus, such as dairy products, nuts, seeds, and processed foods containing phosphate additives, should be restricted. Phosphate binders, medications that bind dietary phosphorus in the gastrointestinal tract, reducing its absorption, are also used. Commonly used phosphate binders include calcium-based binders, like calcium acetate, non-calcium-based binders, such as sevelamer, lanthanum carbonate, and iron-based binders, like ferric citrate. Pharmacological interventions include activated vitamin D, also called calcitriol, or vitamin D analogs, such as pericalcitol, to help suppress PTH secretion and manage SHBT, indirectly aiding phosphorus control. Calcimimetics, such as cinacalcet, increase the sensitivity of parathyroid glands to calcium, reducing PTH secretion and subsequently lowering serum phosphorus levels. For patients with advanced CKD, dialysis is an essential intervention for phosphorus management. Dialysis removes excess phosphorus from the blood, complementing dietary and pharmacological strategies. There are two primary types of dialysis: hemodialysis and peritoneal dialysis. Hemodialysis involves filtering the patient's blood through a dialyzer, which removes waste products, including excess phosphorus. Peritoneal dialysis uses the patient's peritoneal membrane as a filter, with dialysate fluid introduced into the abdominal cavity to absorb waste products and excess phosphorus. Managing phosphorus levels in CKD is a complex but essential aspect of patient care, requiring a multifaceted approach involving dietary restrictions, pharmacological treatments, and dialysis. By effectively controlling phosphorus levels, healthcare providers can mitigate the risk of vascular calcification, bone disease, and cardiovascular complications, ultimately improving the quality of life and outcomes for CKD patients. Thank you again for joining us here on Renal Care Radio.